Afternoon, namaskar to all the colleagues, and on behalf of National Health Systems Resource Center Quality Division, we extend a very warm welcome to Professor Poonam Shivkumar, and I will introduce her a bit later. At the same time, a very warm welcome to all the states, nodal officers from the districts, from the hospitals, NQAS assessors, subject matter experts, and interested partners. Why interested partners? Because the patient safety, the domain, though recently the conversation has started, but some point of time or other, all of us must have experienced either providing care to the patients or as a care seekers, the potential situations where some harm could have taken place, some untoward things might have happened. It may be a simple, say, drug interaction. It could be simple hospital-acquired infection, or the catheter being in place, resulting into the UTI, or even say blood sample has been drawn after the phlebotomy. There is a continuous bleeding. So all of us must have experienced. But unfortunately, it never became the part of the public discourse, except for last, say, 2 years or 3 years or so, when at the international level and at the national level, this thing has started. And since last year, 2 years, we have been also, because the safety forms the basic foundation of any quality endeavor. If we cannot say that we are providing the quality care, but our care is unsafe or potentially unsafe. So I'm thankful to you, and my request to all the colleagues who are connected would be to take this message across wherever you are working in your domain. So every year, in fact, there is a theme which gets chosen. Like last year, it was for the safety of the healthcare providers, rightly so. More so important in a country like India, where there are, in fact, at times, many untoward incidents or other things gets reported in the media. And this year, the theme is safety in the maternal and newborn care. So in this context, in fact, other than having the main, say, event on the 17th, which is the World Patient Safety Day, we thought at NHSRC that let's have a series of short, crisp webinar. And it should not only happen that we come, we hear, go back, and there are a set of activities which, if you can take follow-up of the learning, whatever transpires between you and the subject matter experts, that would be extremely, in fact, helpful. So in that context, let's so can someone confirm if the slides are visible? Yes. I've got the confirmation. So let's start in a bit lighter vein, and which has got a strong message on the right side. That R.K. Lakshman, those of you who have been there reading newspaper and other, there is a joke, it came a couple of decades back, that where the patient is telling to the doctor that you have applied a bandage on my wrong leg, wrong foot. Similarly, while reviewing the literature on the right side, if you pay the attention, you will notice that I've just picked a few things that wrong side surgeries, the incidence depending upon the setting where we have taken, it varies between say 0.2 to 0.3%, maybe 0.4%. And if we take the quantum, it is huge, the impact it will have. And similarly, look at this bit of, again, lighter vein, that all of us working in the hospitals at times as a clinician or as otherwise, the instructions are passed that give this patient plenty of water, plenty of fluid. And in this particular setting, the similar instructions were passed. And what transpired was that an IV drip gets started with the distilled water, and evidence to that thing is there when you look at this thing, that it was nicely demanded from the medical store or the procured, and thing was started. And believe you me, this is in fact the case study from one of the so-called developed world. So, and we don't know what is the quantum of harm we encounter in India. And this is in fact, a few of you must have seen. Perhaps we missed out the acknowledging the source. But you see that healthcare, the harms associated with the healthcare is as good or as bad as somebody going for the bungee jumping. So it just quantifies that quantum of the harm a patient is likely to get exposed when he has come either in the OPD setting or in the indoor setting. So somewhere it becomes important. And similarly, like as I mentioned a few moments back, that patient safety is the base on which, whether it is the question of the equity or the question of, the care being timely, or we take the different attributes of the quality, whether it is the effectiveness, efficiency, or the care being the patient-centered. Until a couple of years back, this whole discourse used to be quite, in fact, in a very open-ended, in the sense that we used to talk that let's get the quality care, let's get the safe care. But the quantum of harm in actual term, in terms of the quantification, so about 2 years back, now it is 3 years back, this data came up. The source is given on the right side. Those of you who are interested can go through. For about 137 odd countries, it was quantified. And it was noticed that about, say, 15.99, say roughly about, say, 16 lakhs people, they lose their life because of the poor quality of the services. Imagine we have, without undermining the importance of the other programs, but it just highlights that how much harm does it take place. And similarly, like there are definitions given by WHO, many different organizations, and which in fact have just spoken. And one of the key component is that the care has to be the person-centered, and the recently being that eco-friendly thing has been also added. And once we are talking about the patient safety, it becomes important because we know that while in the hospital, working in the hospital, the kind of the chemicals are being used, the kind of radiation, the kind of, in fact, other hazardous substances other than the mercury, because nowadays the focus is coming that the hospitals have to be a bit of mercury free, but there are in fact the cleaning material and certain cytotoxic drugs. So whole plethora of these things are getting used, and everything culminates into the care being the person-centric. And this shows that the global burden of diseases, which in fact the most of the countries they have, and typically, like it is estimated that about the 15% of the expenditure. One side we are talking about conserving our resources, So about 15% of the resources are being used in any healthcare setting in trying to address that wherever the safety failure has taken place. It could be hospital-acquired infection, as I mentioned. It could be, in fact, some drug interactions, surgical site infections taking place, which translates into prolongation of the hospitals, prolongation of the stay within the hospital. And similarly, like medication errors, it causes about say 3 to 4% of all the hospital admissions. Though this data is very old one, but imagine that about a lakh people losing their life in a country like US, where so-called they spend so much of their GDP on the health, about 16 to 17% of the GDP on the health. So this is a problem. And what is happening in India? I mean, typically, like we have very less data available in Indian setup, but it is roughly calculated that about the 52 lakhs of the injuries, they take place in India, and I mean, substantial life gets lost. Similarly, I mean, this is a study from one of the hospital that in it's a 300-bedded hospital with the OPD over there. In one study, it was found that about 40 patients, they encounter some kind of the medication errors, and which are really avoidable. So once we talk about the medication safety, it has the many dimensions and many things. I mean, the short point I want to make is that the certain errors, certain say genuine errors will take place. One is that how can we minimize those? And more importantly, the second facet is that what is the learning. In fact, Madam Poonam Shukumar will talk about when she comes in her presentation, that when she talks about maternal death and other things, that what are the learnings which are taking place out of those happenings, so that these things could be avoided. And I mean, it has many dimensions, and I mean, we have tried to capture. Say, for example, if you pay your attention on the left side, on the lower box, in our Indian setup, we have purposely kept the fire safety at the top, because often these may not be the relevant for the developed world. In fact, that has been the rationality. That's why we have kept a separate session on the fire safety, that how do we ensure that our facilities are the safe in terms of the fire and electrical fire. I mean, with the reach of that, with the penetration of the technology, with the the high voltage equipments being used, but our wirings, our say common tendency is there that using the multiple pins or the sockets, putting the adapter over there, and all these things somewhere leads. And often we read in the newspapers, in the media, that so many newborns, they died because of, somewhere the calibration, or there was a fire in the baby incubators. Often we read that when so-and-so hospital is a quality certified, but fire happened and people could not escape. Last thing comes to my mind, that last incidents would have happened in the couple of, in fact, some time back in the state of Odisha. So, but before that in the state of West Bengal, but no state or no facility is immune, because it is no longer horizontally well spread out the buildings. Now the care is intensive. Those patients cannot move out, and there is a pressure on the area. So in that context, it becomes important that we create. And these are the common things which, in fact, in the Indian setup, they are important. First thing is the patient safety incidences related to the surgical procedures. Next being the medication error, and last being on the hospital-acquired infection. So to certain extent, under the quality assurance program, we have been, in fact, trying to address, and those are few who have been, in fact, are associated with the quality, would recall that we have a National Quality Assurance Standard. We have the Kayakalp initiative, which also talks about somewhere having a program for the needleistic prevention. Needleistic injury prevention, infection controls, then pharmacovigilance, hemovigilance, and different say interventions in terms of the facility level audit, whether it is the prescription audit or the maternal death audit or death audit as is in general. And also, I mean, say about 3 years back, the government had launched the National Patient Safety Implementation Framework. This is the work has already gone into. And this is the broad sense, and this has been a well thought out call. That's, the quality assurance framework will also take this agenda forward. In fact, I'm not added the fourth pillar in this, because this thing is not yet formally launched but approved. That we are, in fact, on 17th, we expect that Honorable Health Minister would be launching a new initiative known as Muskan. Muskan is basically ensuring the implementation of national quality assurance standard in those departments which are focused, where the primary role and responsibility is to provide the pediatric care. So in that context. And in fact, these are the certain components which we feel are very well entrenched into the national quality assurance framework. One thing being that, okay, we are in fact very particular about the physical environment, safety and environment, like say safety from the seismic safety, then infection control, infectious waste management, infection control practices, and the safety is in the clinical care, like medication, anesthesia, and related things. But we are also fully aware and candid and trying to address that issue, that which are the areas which are weak with us. And these are the certain areas where, in fact, we do realize that we need to be working further. Our ability to ensure the safe care at the point of care. Somewhere in any safety endeavor, engagement of the patients becomes important. And so the patient engagement, leadership and governance at every level, because for us, whether it is the providing the quality care or the safe care, the certification is important because these are the benchmarks, but we want in real sense some improvement should take place, which also encompasses the safety, and so that we have the safety along the life cycle approach from everywhere, from the baby who has been born, newborn baby, till the time person reaches to the finality. And these are the, in fact, there are patient safety components which are already there, and like ergonomics and customized, managing the work environment. All of you are working on the 5S techniques when we go for the SPT trainings. Those are the dimensions which are being covered. But on the reporting and learning system, it needs strengthening. Then in the certain, say, radiation safety, more so, and more so when the services have been outsourced. The field experience, though unfortunately for the last 1.5 years, we could not undertake the field visits to that extent which we would have wanted. But it is in fact, very often we notice that X-ray machines have been installed. But personal protection and other things, it needs a lot of things to be done. So for the physical safety, like there is the infrastructure safety, electrical safety, in fact, electrical safety audit. These are the requirements. Creating an enabling environment for the staff, visitors, having a proper identification of the patients, medication safety, and in fact, promoting safe clinical processes. This has been built into. And similarly, like we have the very robust component on the blood safety, hospital-acquired infection, and the risk management is the relatively new introduction about 2 years back. Those of you who are working in the INQUAS framework would recall that this has been already built into. And the staff safety, whether it's some, say, female staff doing the night duty or traveling in the night, they are already included. So just a couple of words about the National Patient Safety Implementation Framework. It was launched, but we know that the implementation is at this point of time weak. Now some movements have taken place, and basically it talks about creating an institutional framework. And for the facilities under NHM, meaning thereby district hospital and below, the decision has been taken. It will be the quality assurance framework who will undertake. Then, assessment and reporting. For any safety endeavor, the role of the healthcare providers having the requisite knowledge and skill, having that kind of competency, it becomes important. Infection, I've already spoken. Then safety in the clinical domains, and last being the research component. And this slide explains that where do we stand. It is I'm sorry, it is a bit crowded one. But the core, like on the right side, which is the arrow which is emanating from the center, it talks about that ultimately we want that all the clinical processes which are taking place, it could be the one end of the spectrum could be a complex surgery, other side would be the simple clinical process would be that undertaking the dressing of a patient or removing the post-operative stitches, or it could be just drawing the blood. So safety emanates from there. Then the next in the, if you look at the light pink color, where it talks about having some safety surveillance program, and every organization, every healthcare providing organization, there has to be in a formal way, a program for the quality and safety program has to be there. And then last being having a reporting and learning system. Outside this, like we spoke about that whole thing, it cannot proceed further unless there is a competent workforce. And again, the question of reporting and learning. Why this point features again that normal tendency is there that when something goes wrong, lowermost employee gets punished without going into the root cause analysis that what has been the causative, why that particular things went wrong. So this becomes important. And at the bottom, if you see that culture of the safety or the no blame culture, there is a fine differentiating line in terms of any, say, errors taking place and negligence and the genuine error. So let's try to learn and condone and learn from the genuine errors, try to prevent that. And I'm not trying to advocate that let's condone the negligence part, because negligence is a negligence. And these are the certain key challenges, which in fact we know that we have a long way to go. And this has been just few words about the thematic areas. Like in 2019, after it was adopted by the World Health Assembly, that a global health priority, that was the theme. Then last year it was the speak up for the health worker safety, and this year it is for the safe maternal and newborn care. And why the maternal, is important. If you look on this slide, and I want to acknowledge my colleague, in fact, Dr. Pita Agarwal, who took an effort in putting the information together, that India has done pretty well. But at same time, so have done the other countries. And in that context, though, in the term of the rate of the decline, in terms of the maternal MMR, maternal mortality ratio, the rate of decline for the country had been, say, around 80%, while the global, if you look at the globally, it has been about, say, 45%. Okay, we have done well, but there are states which are still lagging behind. And how do we catch up? And now the low-hanging fruits already have been plucked. How are we going to move to the next higher level? That remains a challenge. Similarly, under 5 mortality also, there is a good progress the country has made. But if you look at this slide, where you will notice that in the neonatal and child mortality, there is a substantial, in fact, mortality happens because of the prematurity, because of the neonatal infection, and because of the birth asphyxia and trauma, which in fact, Madam Poonam Shikumar may talk about. So these things are, not everything, but these are the couple of things which are very much avoidable. So with this background, and I'm stopping over here, and let me have the privilege of introducing the speaker of the day, Dr. Poonam Shikumar. And in fact, ma'am, thank you very much for, I knew you had competing priorities, and you have, in fact, we are grateful to you that you have joined. And she's basically, the professor and head of department, the Department of Obstetrics and Gynecology at MGIS Sevagram. And other than, nurturing and imparting, being a par excellence medical educationist at the undergraduate level, at the PG level, Dr. Poonam has been one of the flag bearer as far as the public health interventions are needed. Like, she had been a clinical skill trainer, she had been the member of many, in fact, the expert groups, principal investigators of many, in fact, whether it was the partograph, whether it is the stillbirth, whether it is the, certain high-end things like low-cost salivary progesterone for predicting the preterm. But her focus has been what are the key interventions which will benefit the community. And she had been, in fact, the co-investigator of the hypertensive pregnancy, then resource person for the government of India, government of Maharashtra, and also a core member of many, in fact, development of the course syllabus. So, ma'am, we extend a very warm welcome. And I know you are, having some problems over there in terms of certain, say, internet connectivity and power supply related issue, fully aware. But within those given challenges, and thank you very much for being with us. Thank you, ma'am, and it is all yours.
Thank you so much, sir. Am I audible?
Yes, ma'am, you are audible.
Okay. So I'll request to put up my slides, please. Thank you so much, sir, and Bhushan, sir, both of you, for inviting me for a topic which is very close to my heart, because what we have developed in MGIMS is all with the support of you people. So I again thank you for that. And this is something which is very, very important for this particular era. And we must talk about the safety in maternal health care, because it has been widely seen in several literature that if you provide a safe and a respectful maternity care, you can reduce the maternal mortality to number of folds. Next, please. Next slide. Next slide, please. Yes, I bring greetings from Mahatma Gandhi Institute of Medical Sciences, Sevagram. This is an institute which still believes in community service and still believes that the doctors which we create should have a rural bias, and they should be, giving the care to the needy people. Now, when we talk about the topic of safe maternal care, the first thing is to know that what are the universal right of the women, which number of us are not aware of. And you will be surprised that when we ask the doctors, our resident doctors, that do you know what are the respectful maternity care rights of the women, many of them did not know. So it's extremely important that we talk about the universal right. Next slide, please. It was actually White Ribbon Alliance which came up with the great initiative for the women, and there were several rights which was mentioned. They were very, very important when we wanted to give a respectful maternity care to a woman. Next, please. And then when we talk about the international childbirth initiative which came up, this was something very interesting, because they took up 12 steps to provide safe and respectful not only maternal health, but also the baby and family maternal care, because baby, family, and mother, they are single unit. If you provide good maternal care, but the baby does not get that good care, and the family does not get the support from the hospital, probably the care what you give will not be safe and it will not be respectful. So the International Childbirth Initiative, which was actually, the seed was born in Canada, where Dr. Andre Lanode, along with his team, developed these 12 initiatives, and you can just put in Google the International Childbirth Initiative and you will get these 12 initiatives. They were the one which actually changed the completely the scenario of the care which was given to the women antepartum as well as intrapartum. Next, please. Now, I am going to tell you the rights of women before we really go into the safe maternal care. And the right itself, the first one says that be free from harm and ill treatment. And this talks about her safety. And just to describe, it's a common habit that, when a woman is delivering or antenatal OPDs which are overloaded, there is a way, the way we speak to the patients, the way we speak to the relatives probably hurts them utmost. The reason being that if a person has come to you for treatment and you talk to her rudely, how do they know that you are, frustrated with the amount of patients are coming to you? You have less faculty, you have some issues at your home. That has nothing to do with the patient. So that is the first right, that there should be no harm. That means the capacity building of the doctors should be there and no ill treatment should be given. There is a right for information to respect her choices, preferences, and companionship. It is always the husband and mother-in-laws who decide who will be inside the labor room, whereas she does not want that. She wants someone else to be there, and that right should be given to her. Privacy and confidentiality is something very, very important, because we all know that whenever we are seeing the patient in heavy rush OPDs, the patient has not even changed and we bring the another patient there. And there is no privacy. There are no curtains, nothing. And one after another, we are seeing the patient, 10 people watching her, who likes to be seen and observed, especially her private parts in front of other, whether even if it is a female, why should she, not dress herself properly and then the other patient comes? Dignity and respect. This is a common problem. Generally, the doctors who are irritated, the nurses who are irritated, they talk very rudely. There's no dignity and no respect given to her. Equality and freedom. You see, this particular right, I would definitely talk, because there's a habit that, and Dr. Bhushan shared with me also, that when he would go with the patient would be treated very well. But if she would go alone, even if she's family member, she would have to wait for a long time. There has to be equity of the treatment, whether it is the collector's wife or it is the most downtrodden women. We say that there should be no gap as far as treatment is concerned. Next, please. Right to healthcare, we have discussed. Liberty, autonomy, and self-determination, that she should decide what she wants. She should be determined what she wants. That she should be liberally given the choices. Right to be the parent and guardian, that is also her right, because she decides when she wants to conceive, when she wants to become pregnant. She needs a conception counseling, it should be given to her. And then right to identity and nationality, and right to adequate nutrition and clean water. So these are 10 rights which have been very, very focused for giving right to the women. Next, please. Now, this was something about the rights, and now what we come on to is the safe maternal care. And my question to all of you would be that, is safe maternal care synonymous to respectful maternal care or not? So answer to this is that safe maternal care is a part of respectful maternity care. If we give respectful maternity care, automatically we give safety to her, and she's very sure that her birthing experience is going to be extremely good because she is in safe hands. Next, please. So there comes the definition of RMC. And when we talk about respectful maternity care, we have to understand that it is basically improving the quality and utilizing the maternal care which is given by every institution. Government institutions are coming up in very big way. People have the habit of saying that, oh, that is government institution, I'll go to private. But believe me, now things have changed. Government of India has come out with such quality improvement programs that many of the tertiary hospitals are much better than any private hospital. And our PHCs, CHCs are also developing in much better way. So respectful maternity care encompasses the ethics, respect, women's feeling, dignity, choices, freedom from ill treatment, and so on and so forth. Next, please. World Health Organization defines good quality maternal and newborn care as that which is safe, effective, timely, efficient, equitable, and people-centered. In a minute, I'll come to tell you what is people-centered. The respect, dignity, and emotional support using effective communication is an important part, which is generally overlooked, and good quality of care recognized as an important factor in promoting institutional deliveries and improved birth outcomes. Now, here I would like to just mention few things that you see people are more bothered about knowledge. And if you see the common public, they want to know a doctor who knows very well, who does very well, but that doctor does not talk to them even for a second. And I'll share an incident with you where my father was operated by one of the very senior person, because my father was a CMO of Allahabad, UP, and he was operated by one of the very senior cardiac surgeon. I wouldn't like to name, but believe me, all the stay he had in the hospital, and in spite of being doctor, he could see that doctor only for 5 seconds, where again he was talking to his doctors and not talking to father. So you can imagine that when you talk about people-centered care, it is the patient who would like to have the attention, who would like to have the care which has effective domain in it, which has attitudinal changes, which has behaviors in it. And that is what is called the respectful maternity care. Please go ahead. So basically, RMC is an attitude that permeates in your word, action, thought, and non-verbal communication. A little smile to the patient. How are you doing? Even if you don't say how are you doing, smile and see at her. Probably that is going to make a difference. So RMC is all about the will to change the behavior for good and about the positive attitude. And where there is a will, there's a way. So all of us are here today. Go ahead, please. Now, this is something which I would like to talk. There is respectful maternity care, which is provider-centric, and there's respectful maternity care, which is pregnant women-centric. So we have always been provider-centric. We decided what property we have to insert, what PPIUCD national program is going on, we have to insert that. We have to ensure that it is inserted. We decide that she is going to deliver in lithotomy position. We deliver her in lithotomy. But now things have changed. Things have changed completely, and we have come on to the people-centered, pregnant women-centered, respectful maternity care. She is the one who decides where she will go. She decides which doctor she's going to choose. She decides who will be her birth companion, and she decides which position she's going to deliver on. So this all has become more of pregnant women-centric. So she has been given full rights to decide what exactly she wants. Next, please. Now, we come on to what are the key features desired for safe maternal health care. So the first and most important thing is create a barrier-free environment. And I'll explain to you what is this barrier-free environment. So let's say there should be infrastructure where under one roof, a pregnant woman can get all the care. There should be good seating arrangement for her. There should be light music running, which will give her, sort of relief during intrapartum period. Okay. So if she wants that she should have analgesia, there should be barrier-free environment. Yes, she wants, she should get. There should be respectful communication. There are two ways to talk. Let's say if I want to talk to you and I take your name and say, Poonam, how are you? Probably that would be better than, yes, you come in. Who are you? So there is respectful way to communicate, even if you have to communicate certain things which are very difficult for them to understand. You can make them in very simple language, communicate in such a way and with dignity that she feels that, yes, I'm in an institution which is going to give me the best care. Respectful quality of care for RMC services. So whenever you talk about antenatal services, you talk about intrapartum services, postpartum services, they all should be evidence-based. They all should be with high quality so that we reduce on the bad outcomes of pregnancy, we reduce on the maternal death, the maternal near misses, and that is going to give her the relief. And then, of course, supportive care should be given to the women during labor. A very interesting thing which Dr. Bhushan and we were discussing was that when a woman delivers, you know, she has so much of pain and she's gone through such a trauma that after seeing the baby, she tries to hold the baby, but she's not comfortable. Placenta is still being taken out, episiotomy is still being sutured. So why can't we have a supportive care to the women? And this supportive care to the women definitely makes a difference, and therefore birth companion nowadays has been made mandatory. Next, please. What are the challenges? Why everywhere we have not been able to provide safe maternal health care? Because yet there is a problem of structural resources. The infrastructures at many places is not the one which has been recommended by Government of India. Government of India is trying, but the area which is there for that particular structure is not enough. So the new wing has to be built up. The human resource is scarce, and this is a common problem in every institution where human resource is not there. And I was studying an article where it was said that where there should be one doctor for, let's say, 1,000 people, there are only one doctor for 4,000 people in some areas in South Africa. So you can imagine that in also we are having very less resource, human resource at different levels, and that is the reason we've not been able to provide RMC. The capacity building of the doctor, the skills of the doctors, nurses, ANMs are not enough. And I'll share in a minute how we have changed the scenario in Wardha district by just building the capacity of ANMs and nurses and doctors. Lack of acceptance, leadership, commitment, work culture, all this is personal. The behavior has to be changed. There's also a lot of financial constraint. So even if there is a will, unless the finances are there, you can't work on that. There are several cultural factors where, the women is not allowed to come to the hospital. And there is one area of Melghat, which is actually a black dot in Maharashtra, where people are struggling to change the behavior and attitude and culture of that particular sect. There's very high maternal mortality and there's very high malnutrition there, but yet it is not changing. And of course, poverty is the another factor, which is a challenge. Then attitude is something which we are again and again saying, unless we change the attitude, probably we will not be able to provide respectful maternity care. Next, please. Then these are few things which I wanted to definitely discuss, that lack of education, unawareness, being dependent on the husband or family. All these things are also creating a lot of challenges for implementing RMC, and violence against women is really increasing. In the COVID era, it has increased nearly triple times in many areas. And so we say that unless we give respectful maternity care, probably we will not know what's happening. The safe maternal care, meaning the safe maternal care is what exactly it is, that when the woman comes to you, we must ensure that we talk to her in such a way that she is able to convey to us what's going wrong with her. And that's why when we talk about safe maternal care, whenever the woman comes, the antenatal counseling is the prime thing which is going to ensure her safety. Next, please. So when we talk about the interventions for safe and respectful maternal health, beyond attitude, there are three pillars which we need to correct: infrastructure, trained human resource, and following all evidence-based protocol with quality improvements. Please go ahead. Now, we have heard what are the challenges. Now, what we have to hear is all about the solutions for providing safe maternal health care. And for this, first thing we have to accept that we are having some problem and we are not able to give respectful maternity care. Then we go by S-bar analysis, where situation, we see the situation, we understand what is the background, we do the assessment, and then we do the recommendations. So identifying the areas which need reform, doing detailed analysis, and then planning a plan for implementation. Next, please. And once we have implemented, we must get the feedback from the women, relative peers. We should modify our plan accordingly, re-implement it, see the results, and then we should advocate. Go ahead, please. So these are the phases. If you want to start a safe maternal health care, select the change which are feasible, acceptable, and cost-effective. Discuss them in details with the team and divide the responsibility of the team. Involve local and district administration. Implement and see the pilot changes. Feedback and modifications are mandatory. See the results. If it has worked out very well, please do the dissemination. Be the advocate and ensure that the policy changes are done for what is beneficial to the people-centered care. How do we provide the safe maternal health care? Let's say an institution wants to start. So there has to be a leader. Now this leader has to ensure that she goes to or he goes to administration, takes the support and looks into the technical and non-technical kind of support, what they want, looks into the financial support. And then once it has been done, then she implements the evidence-based protocols. The team is the one which helps, and this team effort is extremely important when you talk about safe maternal health care. Go ahead, please. Now we come on to the components of safe maternal health care. To begin with, actually it starts with preconceptional period, where a couple comes and they want that we should go ahead with the pregnancy or not. Is there anything you would like to tell us? So from there it starts, but then where we have to focus is antenatal care. Antenatal care should be in a structure where everything can be provided in under single roof. The reason being that this particular woman is pregnant and she doesn't want to go here and there. For investigation, she goes somewhere else. For sonography, she goes somewhere else. For checkup, she goes somewhere else. So that kind of infrastructure should not be there. The attitude and behavior of doctor and nurses should be such that this woman would always like to come to your facility. There should be early registration without even missing single pregnancy, especially when you talk in terms of lower facility. The major problem what is happening is, and the major complaint with antenatal women has, is the time waiting period. So they have to stand for a long time, but that can be reduced. And we, in this institution where I belong to, we have nearly 200 patients a day, but we have made it such a friendly antenatal area that now women feel extremely happy to be there. And then, of course, planning the antenatal visit, which is in accordance to the recommendations by the Government of India. So the 4 visits have to be there, but in case of high-risk pregnancy, you may call them number of times, and we follow evidence-based protocol. Next, please. I have already discussed that these things should be there in antenatal period, but what is more important is integrate birth planning, and that can be done by birth preparedness and complication readiness during antenatal counseling. Friends, we have number of people in our OPDs, but the most important person is the counselor. Because if you have a counselor, probably all your government programs do very well. Your counseling helps the family as well as the women to understand what the pregnancy is, what are the danger signs, when is she supposed to report, how nicely she can be delivered. The fear of pregnancy completely goes off. And as I have already told you, this is the period where you also talk to her during counseling about any violence going on, any other social issues which needs to be addressed. And this is the period where you can also tell her about all governmental programs where nothing is to be done. She does not have to pay a single penny for her antenatal care, intrapartum care, and postpartum care. Next, please. During intrapartum period now, we talk a lot about the infrastructure, and I'll share with you that Government of India has created labor delivery recovery rooms, which have been disseminated. The number of MCH wings have been made, and you will see that these facilities are going to provide us so much of better care as compared to what we were getting. Also, alternate birthing positions are coming up, and in our scenario, I have delivered 463 patients in alternate birthing position, and hydro labor has been done in around 20 cases, and the results have been fabulous. Choosing birth companion, I've already told you, it's extremely good support, and following ideal labor room protocol. These protocols are available in the websites. If you see, they are available, and they talk about the updates which are happening. Delivering the baby, cutting the cord and giving the baby to the neonatologist is no more practice. The baby is to be kept on the mother's abdomen. The cord has to be delayed cut. So it's a delayed cord clamping. And of course, the AMTSL, what is followed has to be followed. Partography has come up in a big way. Previously, people were doing retrospective partography by filling the paper once the delivery happened. But now real-time partograph have come, and so we are going to use those partograph for giving the good care. Of course, supportive care and good practices. Please do not shave now. No shaving, it's only clipping. Do not give enema. No enema is required now. Then, of course, not giving food to the women at all and keeping her hungry, and baby also becoming hypoglycemic should no more be there. It should be a perfect care with lot of support which has to be given to the women. And these are some roles and responsibilities of birth companion, where support encourages and reassures the women. It helps her to breathe, relax, rub her back, and give her sips of water. It talks about informing her about the progress of labor, speak to medical profession on behalf of the mother, help to initiate breastfeeding, support mother in providing newborn care, so on and so forth. Please go ahead. And also these birth companion are very helpful to the places where you have less human resource. So these people, they monitor the 4th stage, they help the women, they tell you number of things When something wrong is happening, they come and inform the single nurse who's rotating all over. But there are some don'ts for these, like do not give any medicine without doctor advice, do not encourage women to push, do not give any advice to expectant mother other than given by the health worker, and do not administer any local or herbs or medicine, so on and so forth. There are a lot of advantages of these birth companion, in which one I have already told you. It prevents baby swapping, it provides emotional support to her, helps in breastfeeding, especially the early initiation of breastfeeding. And then of course, it provides in some or the other way, because of emotional support, less pain during labor. So overall, it gives a very positive birthing experience, and that's why the government says that birth companion should be mandatory now. Please go ahead. Then we come to the major part of it, that during intrapartum period, we see that a lot of hitting happens, a lot of abusing language happens, loose talks happen. So it's a very clear guidelines now that these things are unexcusable and they come under criminal law. And I will tell you and share one incident with you. I was working in outside country in a place where, just next to me, a doctor was operating. And while operation, that doctor said, "Oh my God, what will I do? What is this?" And this woman was under spinal anesthesia. After coming out, this woman sued the doctor, saying that when my doctor, whom I trusted, said that, "What will I do?" It made me feel absolutely nervous, and my blood pressure fell down and I was very uncomfortable. And you will be surprised that the court said that such kind of loose talk should not be there, and the penalty was given to the doctor. So this is something extremely important, which I wanted to talk. And then your language and the communication, not only to the women, but to the relatives, should be in a very respectful way. Please go ahead. Now, this is a very interesting slide, which has been made in such a way that all of you, if you have this kind of labor room setup, please go and see your labor rooms and ensure that you can provide this kind of setup. It's going to really make a difference. Go ahead, please. During postnatal period, of course, the careful monitoring of both stage has to be there. Encouraging initiation of early breastfeeding has reduced neonatal mortality significantly. Even in COVID era, KMC and breastfeeding have never been stopped. The tender loving care has to be given. And of course, the feedback in the form of Mera Aspatal or local feedbacks using papers can be done. The discharge paper is one of the very important component, because it tells you how your facility is. So it should be very properly done. In emergency also, it is very important that this woman should have safe maternal health care. Why? Because already she is in a state of, shock, or say eclamptic, say she has postpartum hemorrhage, anemic. So this woman needs a very swift management. Triage, obstetric ICU, and HDU, and the OT where the women can be taken directly are the infrastructure which have to be there. Helplines are the one which have helped us, and I'll share in a minute how helplines help you, because if you integrate the facility right from PHC to the tertiary care hospital, these helplines will tell you that a serious woman is coming to you, and you can be all prepared taking her to the operation theater directly. One has to have emergency response team ready, where your anesthetist, your doctors from gynae, OBS, your pediatrician, critical care consultant, all have to be there. And then there have to be protocols, checklists, and one very important thing is debriefing. Now, this debriefing is that if a scenario has happened, once the patient is settled, you all should gather together and see what was good and what was bad. What was good, you need to ensure that that is followed next time also. But what was bad, you have to look for the solution. And then you have to repeatedly do these quality improvement cycle so as you can make your facility the best. Documentation is extremely important when you're talking about safe maternal health care. This is from both the points. One, to save yourself from medical legal issue, and second, to ensure that with your documentation, the further treatment what is given is the best. The major problem is referral protocols, which are never followed from the lower facility to higher facility, and their problem happens. And then, of course, following these evidence-based protocol, I'm not going to go in details, but what I'm saying is, like, you follow PPH bundle, eclampsia bundle, infection prevention protocol, how to divide your team into in charge, assistant, supplier, and informer. If you divide the team into 4, you will see no chaos in your setups. Go ahead, please. We'll quickly go ahead. So these are evidence-based protocols. This is something which I would like to insist upon, that emergency drills for anything, do mock drills, keep doing drills for PPH management, eclampsia management. And when you do these kind of drills, you are going to see that these drills help you so much when the case scenario is real. Go ahead, please. Audits are extremely important. Just now, Dr. Shastro was saying that audits are very important to know. So facility-based audits for deaths, why they are happening, near-miss cases which are coming, cesarean section audits, why surgical infections are happening, referral which are coming, how they are and what needs to be changed. These audits are very, very important. They should be done in the facility and then disseminate the findings to the person concerned so that the response can be done, the solutions can be made. And these are several government schemes. You see, Government of India is efforting so much, to make things better. Laksh has come up in such a way that the labor room scenario and OT scenarios have changed completely. Mera Hospital has given us so much of feedback. You will be surprised that government has created nearly 400 MCH wing, which have been sanctioned to provide safe maternal health care. And there are so many programs, all of us know, JSY, JSSK, now Suman has come in, and now SRS and Muskan is coming. So many programs are coming. They need to be implemented. They need to be disseminated. Next, please. And very quickly, please run the slides. This is our experience on respectful maternity care and safe maternal care. We have created this infrastructure in the most rural area of Maharashtra. These are our obstetric triage, where we put the 4 colors as the women comes and we treat them accordingly. Go ahead, please. Quickly run the slides. These are services available. OPDs have display so the women does not have to wait. There's a counseling area where the counselors are continuously sitting. OPD and investigations, etc. Everything is under one roof. You can see our antenatal ward, which are very, very lighted and very, very airy with central suction oxygen. Go ahead, please. These are our high dependency unit and obstetric ICUs. Go ahead. Operation theater. This is, I am talking in an area which is very, very rural. Level 1, level 2, level 3 NICUs, which are almost full. Rather, we are going now 100 to 120%. These are our postnatal wards. And we have a skills lab where continuously people practice before doing anything on the patient. And then we have a suggestion box where often then the nurses, the doctors, the resident doctors, the attendants, they put their suggestions and we ensure that we follow them. Please go ahead. So friends, these are some pictures which are showing that we are following the PPH emergency response and then we are doing debriefing after we have finished the scenario. These are the different methods we have developed for alternate birthing position. There's hydro labor, there's chair labor, bar labor, ball labor, you can see, and these are all developed by us. We have not purchased anything because if you purchase, they come into nth cost. But when you do it yourself by ensuring that they are cost effective, probably they help a lot. This is our pre-labor counseling and birth companion all the time with the patient. And then, of course, we do not stop till the hospital. We go to community. We do system integration. We do facility readiness where we go to the facilities, we teach them what is a referral protocol, what referral protocol they have to follow, like the slips should be completely filled, ambulance should be arranged, communication should be done to the referral facility, the number should be available with them, so on and so forth. And of course, we look into the teamwork and all. Now, these are some pictures where we directly go to facility rather than calling people from facility to the medical college. Go ahead, please. So these are some pictures. Please go ahead. So finally, to end of my presentation, I would say where there is a will, there is a way. We all want to give respectful maternity care. Please take the leadership, ensure everything is available in the literature, everything is available in the government guidelines. All what we have to do is to ensure that we take the leadership, do the changes, and do the changes according to the women's desire, and ensure that we give respectful maternity care to each and every woman who's there. Thank you very much.
Thank you. Thank you so much, ma'am. Doctor.
Thank you, sir.
Thank you very much, ma'am. And allow me to express NHSRC appreciation for your stimulating speech, very lucid presentation on the first day of this Rogi Suraksha Saptah on safe maternal healthcare. Ma'am, we are very grateful for you, for your time and efforts which you have given for us. We know that you are, I think, traveling, and during that time also you have presented your presentation on respectful maternal healthcare, and we are very grateful for that, ma'am.
Thank you, sir. Thank you so much, sir. It was an honor because NHSRC has been doing so much for the public health. If we can contribute a little bit, it would be our pleasure, sir. Thank you very much.
Ma'am, thank you, ma'am. I believe all the participants who has joined today definitely get benefit from your talk, and they will definitely implement in their healthcare facility. Thank you once again for your contribution, ma'am. And we will try to incorporate all the things which you have shown during this presentation, whether it is safe maternity healthcare, whether it is RMC, whether it is about the birth companion. The facility will definitely try to implement all these things in their healthcare facility.
Thank you, sir. Thank you, sir.
On the behalf of NHSRC, I would also like to express my thanks to all the participants who have joined today. We know that during this Suraksha Saptah, they all might be busy, but apart from doing their activity during this Suraksha Saptah, they have attended this webinar, and we are very grateful to all of them. Yes, we will definitely do this kind of thing on the next 6 days again. So all the best, and we will join tomorrow at the same 2 o'clock, and we will discuss about the safe newborn healthcare. Thank you once again. Thank you, ma'am.
Thank you. Thank you, sir.
Can we close this meeting now?